Good evening, friends, and a warm welcome to the 8th episode of Season 3.0, 4D. And 4D, as we all know, stands for Detailed Discussion and Dialogue in Diabetes, in Indian Diabetes. This is episode 8, and the number 8 is very important in diabetes care. You've seen Dr. DeFronzo speaking about the ominous octet. But always, when I was younger, and then I was not so young, and I'm not so young at all, I never liked the sound of the word ominous. I like the number 8 though, because I like octopuses as well. So a quiz question for all of you. What is that philia? Like you have phobias and philias. So what is the philia, which is a philia or a love for octopus? Coming back to the number 8. So I never liked the sound of the word ominous. And then when I grew up, I realized that we can always look at things in a positive manner, from a positive perspective. So instead of talking about the ominous octet, we started talking about the octagon of opportunities. This is one such opportunity today, the 8th episode. So let's welcome 3 very optimistic, very friendly, 3 forward-looking experts. A warm welcome to Dr. S. Arul Murugan, a diabetologist at Puducherry. Warm welcome, sir.
Thank you, sir.
Dr. Arul, entire India watching you, and the question from all your colleagues is, what does optimism mean to you? As a diabetologist, are we supposed to be pessimistic or optimistic? Let us say somebody comes with diabetic foot to the clinic.
So, first I would like to gain confidence from the patient. Because the moment we say diabetes as a major disease with a lot of complications, the patient's inclination towards regular therapy and going forward with protective, aggressive management will be lost. So rather telling about the complications, first we should tell about the possible available interventions to prevent complications to be told to the patient. And we should rather tell them that we can easily prevent complication if you cooperate, rather than you will get complications if you are not cooperating. So definitely optimistic approach will be helpful in patient management.
Thank you so much. And on this optimistic note, let's welcome Dr. Thiru Vikram Prakash ji. Dr. Thiru Vikram Prakash is a cardiologist practicing at Villupuram in Tamil Nadu. Warm welcome, sir. Dr. Prakash, in Hindi and Sanskrit, the word Prakash means light. So, what has happened to cardiology in the last 2 to 3 decades? Have we moved towards darkness, or actually is there light at the end of the tunnel? How has cardiology evolved?
Yeah, over the last decade especially, so introduction of new drugs and introduction of interventions are being shaped into much precisely we can do much better things what we were there in 2010 and what we are now in 2025. Last 15 years interventions are at its peak now, to tell it. And regarding medical management also, optimal guideline therapy. So 1980s it started with just aspirin alone, and beta blocker joined it. So presently we have 4 pillars, and all have a very good relative and absolute risk reduction. So presently both medical management as well as interventions, we are going into Prakasam, what you will tell in Tamil. So we are going into a very good shape as far as cardiology is concerned. So except for 1 or 2%, just 97 to 98% of people, whatever the problem may be, we are able to give a cure to them. So as far as cardiology point of view is concerned.
Sir, a comment for you. This comes from Dr. Vijay Bhaskar Reddy, who is an endocrinologist in Puducherry. He says, can you explain this concept in Tamil that you just mentioned about? Can you explain it in both Tamil and in English for our viewers? This concept of optimism, of positivity.
About positivity in the sense?
The Tamil word that you used. Can you explain it in both Tamil and in English for us?
Yeah, Prakasam means it is நம்ம ஒரு ஜோதின்னு சொல்லுவோம், ஒரு பிரகாசன்றது வெளிச்சம்னு சொல்லுவோம். ஸோ ஜோதி வெளிச்சத்தை தான் நம்ம வந்துட்டு பிரகாசம் சொல்லுவோம். ஸோ நம்ம ஒரு பாசிட்டிவ் வைப் இதையும் வந்துட்டு பிரகாசம் சொல்லுவோம். ஸோ இது எல்லாமே வந்துட்டு ஒரு ஆப்டிமிஸ்டிக்காக வந்துட்டு பேசும்போது அதுக்கு ஈக்குவலன் டேர்ம்ஸாக வந்துட்டு யூஸ் பண்ணுவோம் சார் இதெல்லாம்.
You know,
So it
then
is
Dr. Thiru Vikram, is that if I hear with the Sanskrit ears or with Hindi ears, what I'm hearing is a light, glow, the sun. So that is the kind of vibe I am getting, positively. Yes.
yeah.
So there is light. So thank you so much. And we are joined by Dr. Kavya. Dr. Kavya R is a nephrologist. She is consultant at Sri Venkateshwara Medical College in Puducherry. Now, the word Kavi, that is masculine, and the word Kavya, that means poetry. So, Dr. Kavya, how has nephrology evolved? Is it true that earlier nephrology was a kind of, dead end kind of specialty? When there is no life left in the patient, then you refer the patient to the nephrologist. But now the nephrologist is actually able to write such beautiful poetry for the patient's life, and you can live a beautiful life under the care of a nephrologist. Is that correct now?
Yes, sir. Thanks for the introduction, sir. Actually, nephrology has evolved a lot over the last decade. Previously, the only solution for renal failure used to be dialysis. But now we have a lot of options. We have preventive measures, we have therapeutic measures. We have got a lot of drugs on the pipeline now. So in future, there will be a lot of preventive nephrology, therapeutic nephrology, transplantation, everything is going to be changing the lives of patient a lot.
Thank you so much. And all of us who are logged in, a warm welcome once again to 4D. And like you already seen, we have some of the most positive looking and dynamic experts from across the country with us. So, Dr. Arul, our topic for today is where guidelines converge. Before we talk about guidelines, let's talk about disease. Is diabetes different? Is heart disease different? Is kidney disease different? Or do you see an overlap in your clinic?
So definitely there is a overlap. It is a kind of metabolic disorder which ends in various presentation, various organs. Like if you take the metabolic aspect, it results in insulin resistance results in hyperglycemia. In cardiovascular aspect, it produces atherosclerotic vasculitis and heart failure. In renal aspects, it can start with albumin to the over thyroid kidney disease. And it also affects other parts like brain. So diabetes per se cannot be seen as a single disease. Rather, it is a factor which is a kind of metabolic abnormality which produces other side effects involving other organs, especially the kidney as well as the heart.
And Dr. Prakash, it has been said that diabetes is a cardiac disease. Would there be merit in this statement? Would you like to discuss the statement, pros and cons? Diabetes is a cardiovascular disease.
Yeah. Pros, as you said, 10 years of diabetes, and especially if it is uncontrolled, it is almost a cardiac disease only. So we can, for sure, you can tell either patient will develop a macrovascular complication in the form of ACS, coronary artery disease, and if there is no macrovascular complication, at least you will have endothelial dysfunction related heart failure with preserved ejection fraction. So 10 years of diabetes is equivalent to coronary artery disease only. And though we have peripheral arterial disease, stroke, so all these, and the third one is obviously cardiac. So all these combined, if you see the ratio, the first will be coronary artery disease only, and practically also you will be seeing more of macrovascular complication. The first you will be seeing will be coronary artery disease in diabetic patients, and rest two will be slightly lower than that. The chances of getting PAD, because it is about the vessel size basically. So coronary artery vessels are just 2 to 3 millimeters. So patient obviously will start developing plaques in the smallest vessels of the body, so which is coronary artery. And stroke concerned, it is second affected. It is more of hypertension will create stroke. Diabetes is more concerned with the coronary artery disease. And third will be peripheral artery disease with respect to incidence also, because vessels will be 6 mm, 7 mm. So third will be the peripheral artery disease incidence. So we can directly equate diabetes mellitus to coronary artery disease after 10 years of diabetes.
Thank you, sir. And one other thing we would like to highlight for everyone is that This is partly true that diabetes causes complications. What is even more true is that uncontrolled diabetes causes complications. That would be the full sentence. So when your patient comes to you, when your patient comes in a sad mood, patient is distressed, patient is afraid, patient has read so much from the net, all right things, wrong things, the least we can do is to provide what we call psychological first aid. And you see Dr. Arul, Dr. Thiruvikram, Dr. Kavya providing that psychological first aid through the way they speak in such a soft and sober and yet emphatic manner. So if you are able to provide the psychological first aid, that okay, you have diabetes, but diabetes will not cause any complication. It is only uncontrolled diabetes that causes complications, and control is in our hands. Dr. Kavya, but see, Dr. Prakash now, he has said that the degree of complication is inversely proportional to the caliber of the artery. That is what he is telling us. Then what about the microvasculature, like the kidney, the retina, the nerves? Nobody talks about that. Do you think that the microvessels are being discriminated against by all the big boys, by all the big vessels? And they are bullying us.
Sir, approximately 40% of diabetic population develops renal disease. But the sad part is that most patients who develop kidney disease reach nephrologist very late. This is because of the delay in diagnosis of early kidney disease in these patients. So all diabetic patients need to be screened for underlying kidney disease in the earliest stages itself. So a minimum urine examination will be sufficient to diagnose early stages of diabetic kidney disease in these patients. So unfortunately, the fundus examination, the microalbuminuria are missed in these patients. So we need to concentrate more on diagnosing the microvascular complications as well.
So we have talked about the disease. Let's move to diagnosis. And Dr. Arul, Dr. Nitin Kapoor, he is professor at CMC Vellore. He says, why all this colaveri? Why are the cardiologists speaking in different tone and nephrologists speaking in different tone? Is it not the same human being, and is it not the same vasculature, the same endothelium? So Madam just spoke about microalbuminuria. Can we use albuminuria as a bridge between macro and microvascular complication screening?
Definitely, sir. Like albuminuria is one key point by which we can identify the referropathy much earlier. But I would rather we cannot wait for a sequential event every patient. The event in every patient is different. Just because a particular patient doesn't have a microalbuminuria doesn't mean that he will not have a cardiovascular disease. I would rather each and every patient should be viewed individually based on the duration of diabetes, other risk factors like obesity, family history of coronary artery disease, maybe added risk factors like smoking. All those things should be put into the mind, and we should assess the risk for probable ASVD risk or heart failure risk or CKD risk individually. Though it's a good idea that microalbuminuria can be taken as a bridge, but that should not be restricted only with microalbuminuria, and other parameters and phenotyping of the patient and risk factors should be monitored carefully, and we should choose different kind of approach for different patient. And of course, we should stick with the algorithm given by various guidelines like monitoring for retinopathy, annual monitoring for nephropathy in case of albuminuria. Those things should be monitored for every patient.
This is also important, and thank you for highlighting this. Just like we talk about the octagon of opportunities, we have changed from ominous octet to octagon of opportunities. We have multiple opportunities for screening, for early screening, early detection. So that, like Dr. Kavya said, the patient doesn't come only in the late stage, patients come early for treatment. But Dr. Prakash, speaking from a cardiology OPD perspective, now of course there are some patients who have established ASCVD. They have already had a stroke, or maybe an amputation, or probably a myocardial infarction. Let us keep them aside for time being. The ones who are at high risk of ASCVD, or maybe moderate or low risk, how do we calculate the risk? What can we do in India? How can we calculate the risk of developing ASCVD if someone doesn't already have it?
Yeah, we already have a score for ASCVD, so less than 5% and 5 to 10%. So we will be usually approximately we will be keeping it ASCVD risk score more than 7.5% as a risk factor for all the cardiovascular adverse effects. So we will be taking into account diabetes, age more than 70, and mainly LDL levels, HDL levels, and also waist circumference, I think. So all these 5 included, we will be calculating the score. And if ASCVD score is more than 7.5%, then they will be in the intermediate risk group. And directly, if LDL level is more than 180, so they will be going into the high risk group. If they have any of the macrovascular complication like stroke or myocardial infarction, so any macrovascular complication, so directly they will be going to the high risk group. And ASCVD risk score of around 7.5% and above, so they will be in the intermediate risk group. And ASCVD risk score less than 5%, they will be falling in the low risk group. So most of the OPD patients, whatever we are seeing, most of them will be coming in the intermediate risk group. So we will have to check cholesterol levels. There's a lipid profile level along with the waist circumference. So that will be enough to calculate the risk score. It will be very easy to categorize them either as high risk or intermediate risk or low risk. We need not do much blood investigation. Simple lipid profile and waist circumference along with their age and whatever risk factor they are having. With that, we can calculate whether they fall in the high risk or intermediate risk or low risk.
And the nice thing is that you can use this to tell your patients that, of course, some risk factors are not modifiable. For example, male gender or maybe the age. But others are modifiable, like LDL cholesterol, like body weight, so you can easily act upon them. Dr. Kavya, madam, what about nephrology? Do we have any risk scores or maybe risk maps, heat maps? What can be used in the routine general OPD for kidney risk?
So any diabetic who comes to the nephrology OPD, we do a BP measurement. We look at the volume status, and then we do a urine examination for albuminuria. In places where urine albumin creatinine ratio is not available, we can do a urine protein creatinine ratio or a urine dipstick for albumin. Apart from that, we do creatinine and calculate the EGFR. So we don't have any risk score. Based on this, we manage the patients. Apart from the renal evaluation, we do workup for other macrovascular complications and microvascular complications. Like we evaluate the cardiac status. We look for retinopathy. We look for peripheral vascular disease. We look for neuropathy. So all the macrovascular and microvascular complications are screened for. As sir said, we do a lipid profile also.
Madam, could you describe the KDIGO heat map for us? What is the KDIGO heat map? There are so many colors in it. It looks like a map of India and Maldives and Nepal all put together. So how do we interpret that map?
It has 2 arms. So one is the EGFR. Based on the EGFR, there are classifications. And based on the albumin creatinine ratio. So based on the albumin creatinine ratio, we classify them into A1, A2, A3. So A1 is normal to mildly increased, A2 is moderately increased albumin creatinine ratio, and A3 is severely increased. And similarly, based on the EGFR, we calculate using the equations which are available. So based on that, we do classify them based on the EGFR into 5 stages. So the reds, green and yellow classifies them into the low risk and high risk. Based on the albumin creatinine ratio and EGFR, we classify them, we stratify them into different risk.
Dr. Murugan, when we look at the statues of Lord Murugan, we see that he has got so many arms. Not only 2, not only 4, not only 8. In some statues, he has got 12 arms. Do you think that diabetologists should work like Lord Murugan, doing 12 things at the same time? Can you put everything together for our audience? We are screening now, for complications, and we are trying to achieve common ground.
Sure, sir. So actually, Dr. Kavya has clearly pointed out that most of the patients are coming late to them. That is mainly because if we see the staging of the CKM, the stage 1 starts with the risk factors like obesity and insulin resistance. Stage 2 is like overt metabolic dysfunction. And the stage 3 is a subclinical, stage 4 is the obvious CKM. So most of the time, the patients presents to the specialty at stage 4 and rarely at stage 3. And as a physician, my role is like when as primary care physician, when a patient comes to me with like may not be coming for the diabetes per se, maybe coming for fever or something. If patient is stage 1, having signs of insulin resistance or high obesity, this is a time I should start intervening, prevent them to progress to the next stage. By just if I'm seeing them in the stage 2, where the over diabetes or dyslipidemia, I should always screen the patient for other possible metabolic abnormalities and assess the possibility of subclinical heart failure or subclinical CKD, and most importantly, timely refer to the specialist. For example, I know not should I wait for the GFR to go down below 30 or albuminuria become an overt proteinuria or like irreversible CKD stage, or I should not wait for the patient to develop a massive myocardial infarction before referring to the cardiologist or a nephrologist. So as a physician, I should keep my arm widely open and look for all the screens, and I should not hesitate to refer the patient to the specialist at the right time. So by doing this, definitely we can enhance the decrease the morbidity and mortality among the patients.
So when I joined practice, and this was more than 2.5 decades ago, I used to face a lot of challenges. I was the first endocrinologist in my state, and there was a very pessimistic, very passive kind of attitude towards diabetes care. I still remember one religious leader coming to my OPD. She was nearly blind because of retinopathy, but we started insulin and we told her, Madam, see, you still have some eyesight, and this was more than 25 years ago. So we will be able to help you. We will be able to help your kidneys, your heart. She took the insulin, she went back. But then when I was going home, I happened to cross her compound, where she was preaching. And there what she was saying was that you have got diabetes because of sins that you have incurred in your previous life. Therefore, it is your duty to suffer from the complications of diabetes. That hurt me a lot. And then I began thinking, how do we motivate our population to sort of be more proactive in diabetes care? And then the inspiration I got, Dr. Arul, from your name. So when you see Lord Murugan, in some pictures he has 4 arms. In others he has 12. In others he has 22 also. So then I began telling my patients, do you worship God? So the answer is yes, we worship. So how many arms does Lord Murugan have? How many arms does Durga Mata have? So the answer is multiple. So then we began saying, see, we have got multiple treatments for you. If diet and exercise doesn't work, then we have got tablets. If tablets don't work, we have got insulin. And now, of course, thanks to all the newer developments in nephrology, cardiology, diabetology, now we have got innumerable permutations, combinations. So Dr. Prakash, in your OPD, do you find this pessimism and passive approach sometimes from patients? And how do you instill that optimism, that hope in them? Any challenges that you have faced in your OPD this week, and any solutions that you created?
Yeah, there will be a lot of pessimism. So as Arul sir said, so at least he will have some upper hand. They will come at least when diabetes is diagnosed, and sir can have some time to have a treatment protocol with them, and before complications develop. But most of the patients whom I treat, so other than OPD patients who have a non-cardiac chest pain and just they come and go, so rest all patients will be having complication. After developing some complication, they will be coming to a cardiologist. Either it is a heart failure or a arrhythmia, so or a valve or heart disease, so whatsoever. So mainly in this heart failure or CAD group, diabetes will be most common. And as you said, blind. So last week I saw a blind person. He is a diabetic patient. Ophthalmologist had first seen him. So already he had one blind eye, and second also was having some problem. So he went there to ophthalmologist, and he had referred for a cardiac evaluation. So they had given some ciliaretinal artery occlusion. So on my examination, I saw that patient was having heart failure with preserved ejection fraction, and there was a AF also, atrial arrhythmia, AF going on with a fast ventricular rate. And so I could easily point out that most likely this was a embolism, and that it was not a direct diabetic retinopathy causing the blindness which he had in the previous eye. The second eye, the present problem was the occlusion was due to AF and the embolism which has caused his vision. So at that this palpitation he was having for a long time he was having, but he was not worried about that since he was sedentary. He was managing with that palpitation. So at one point of time when his eyesight was a problem, he had went for ophthalmologist opinion. So then he had referred, and we had reverted the AF. So we're to sinus rhythm, pharmacological cardioversion, and with that NT-proBNP was 6,000 or something. And within a week or two, that is this week when I repeated, NT-proBNP had fallen totally. It has come to almost 500, 600. So everything he was settled, but the eyesight did not return. So it was a sad thing that he had come to sinus rhythm. His heart failure, he was much better. Symptomatically, he was much better. He was on drugs now, anticoagulation, everything was put. So he was asking me, so many problems have come down now. Palpitation has come down now. Breathlessness has come down now. Will my vision return or not? So I couldn't answer that. So, and when I saw that after 1 week, it is highly impossible. But I couldn't tell him in an optimistic way. How can I tell him that he was already on vision on one eye, and now that has also gone due to cardioembolism. So like that, he couldn't explain that in an optimistic way, that will be stuck around. What we can do is at least give him some empathy, some words, and yes, sometimes we will be in that state only. If at all he has come for some acute reason, so we'll have something to treat, and once he is better, then it's okay. At least half of that is better, then also it's okay. When totally something is gone, then whatever optimism we take, patient will not take it. They will be already in a sad state of mind. We can empathize for them, but ultimately it is a loss for the patient only.
Dr. Kavya, in your practice, many times we label patients as having chronic kidney disease and maybe diabetic kidney disease. But maybe any experiences that you have had where actually patient had only acute kidney injury and there was a different etiology, maybe pre-renal, maybe post-renal. You fixed that up and the patient got a very healthy pair of kidneys again. Anything coming to your mind, madam?
We do see patients recovering with appropriate treatment after acute kidney injury. For example, a patient whose baseline creatinine was 1.2, he had some fever, cough. He went to a local medical shop and he took some over-the-counter drugs. So after 2-3 days, he developed pedal edema. He was breathless. He came to us, and his creatinine was around 3 to 3.5 at admission. So we gave him some diuretics, and then we did a biopsy suspecting acute interstitial nephritis due to the NSAIDs and antibiotics he had taken over the counter. So the biopsy report was acute interstitial nephritis. On withdrawal of the drug and with adequate diuretic response, his creatinine came back to 1.3 to 1.5. So not all the times the renal failure is due to diabetic kidney disease alone. We need to evaluate them for other causes like pyelonephritis, acute interstitial nephritis also. So all these play a very important role. Sometimes even a heart failure, acute worsening or acute heart failure can cause an elevation in creatinine. So we need to evaluate, considering the history, examination, clinical features. We need to draw a conclusion.
This is really important. Like, for example, you spoke about heart failure. So what happens? We use NT-proBNP as a screening tool for heart failure. But patients with CKD will have higher NT-proBNP by default. And people who are obese will have lesser NT-proBNP by default. Similarly, when you check the EGFR, that will vary based upon the obesity, upon the body weight. So it may not be fully accurate. It can also vary according to age. And you might have, artificially low EGFRs in elderly people. Dr. Arul, what is the role of the physician in all this? And we have people listening to us from across India. What we are realizing is that the more we learn, the more light we get, that is Dr. Prakash, the more darkness we seem to go into. So, your experience as a physician, anything coming to your mind where maybe you made a mistake that you would like to share with us? Don't make it. Maybe you actually got that something right because of maybe good luck. Any patient coming to your mind, sir?
So first I say the one patient which I missed actually. Recently one patient with severe anemia and non-diabetic an irregular follow came with the HbA1c of 11.2. Came with severe dyspnea and I admitted the patient. We saw the urea was somewhere around 80 and creatinine was 4.8. The hemoglobin was 4. And we started blood transfusion evaluating, and we fixed the mind as a CKD because of presence of anemia and constituting diabetes. Finally, on after multiple few transfusions, once the patient volume state is improving, the renal parameters significantly came down. It turns to be anemia with failure, and the whole scenario is a renal failure. So at times, just because seeing the duration of diabetes and other factors like anemia, we fix our mind that it is a CKD. In fact, I just left a word to the patient that this is a CKD, so that's the reason I don't want to give multiple transfusion. Those kind of counseling I started giving to the patient. But finally, after a few days, creatinine level has come down markedly and turned out to be acute kidney injury. So, as Madam said, we should always keep the other things in mind before fixing the mind, diabetic related complication in patient clustering with or mimicking the complications.
Let us involve Dr. Prakash in the discussion. Let's talk about anemia. But before that, Dr. Murugan, while we ask Dr. Prakash, there is a question for you from Haryana. Dr. Suneet Kumar Verma says that he has heard about the Thirukural, which is the Tamil epic. So perhaps when we come back to you, could all of you one by one tell us what the Thirukural is and your favorite verse from the Thirukural, which helps you become a better doctor? That is a request coming from Haryana state. In the meanwhile, Dr. Prakash, we speak about heart failure with preserved ejection fraction, restricted ejection fraction, and our cardiology colleagues are fond of, finding newer terms like moderately restricted and things like that. But when we were students, we used to have heart failure with increased ejection fraction. The three differentials that I am aware of are severe anemia, like Dr. Murugan said, AV fistula, which Dr. Kavya deals with every day in her practice, and uncontrolled Graves' disease, which used to be in endocrinology. Sir, does this term still exist, heart failure with increased ejection fraction, and how do we manage it?
Yes, sir. So you are told already all the diagnosis, and other thing is beriberi. So thiamine deficiency. So all these things, hyperkinetic. What we tell it is a hyperkinetic myocardium, and we can tell in that other way also heart failure with increased ejection fraction, and relatively we can add regurgitation, valvular heart disease regurgitation lesions also, severe AR, severe MR. So all those things, ejection fraction tends to be around 70% on the higher side. So clinically we can differentiate them by just simple palpation of pulse and also bounding pulse, and we can by blood pressure means we'll have a decreased diastolic blood pressure, and we will have a collapsing pulse sometimes. So we will be able to differentiate them, and once we think about rest of the investigations like ECG will have a tachycardia, and echo wise we will be easily able to find out the Doppler. There will be increased turbulence in all the chambers, and if you put a pulse wave across any valve, especially pulmonary valve and all, so we'll be able to see unusually increased turbulence in patients with severe anemia, thyrotoxicosis, so fistula. So all these patients will be able to easily find out by echo. So this is some turbulence will be there. So then we will be thinking about etiology. So what is causing this increased turbulence? And if we see the investigations, we will be able to find out from blood investigations whether it is anemia or thyrotoxicosis. And sometimes beriberi also can present in that way. Sometimes it will be decreased ejection fraction also, reduced ejection fraction also beriberi can present. So whenever there is a heart failure, when we are not able to find out anything, there is no anemia, that is with the increased ejection fraction I am telling, not able to find out anemia or thyrotoxicosis. So in that case, just we can blindly put a thiamine tablet, and it will work wonders sometimes, especially in children. If a patient is, if a kid is having unexplained severe pulmonary artery hypertension, and before labeling it as a primary pulmonary artery hypertension, if you give time in therapy for 2 to 4 weeks, then sometimes you will be able to see totally the pulmonary hypertension will disappear. So then retrospectively we can make a very diagnosis. So seen many patients like that during my residency days. So clinically and also by investigation wise we can find out that patients whoever they are having a ejection fraction, that is increased ejection fraction, we can have a clue and we can diagnose that.
This is very nice information. It is new for me. So just like we say Wernicke's encephalopathy, now I will begin calling this syndrome Dr. Prakash's cardiomyopathy. And is
And
important
unexplained cardiomyopathy, so even peripartum cardiomyopathy also, giving blindly thiamine sometimes helps actually. We'll have within 2 weeks, 3 weeks time, but peripartum we don't have much evidence, but usually we give thiamine in any cardiomyopathy, not even just in alcoholic cardiomyopathy, but in any cardiomyopathy we give thiamine as a drug apart from all four pillars of heart failure. So fifth we will be adding thiamine for any cardiomyopathy in private practice.
Thank you so much for this advice, and I'm sure all of us have gained from this. And when we come back to you, sir, the same question is, which is your favorite verse from the Thirukular and who was Thiruvalluvar? But Dr. Kavya, Dr. Prakash just spoke about the pillars. Now in nephrology, you see all the complicated kind of patients. And I think there is no permutation combination that is humanly possible, which is not there in nephrology. So ma'am, what are these 4 pillars? Could you just describe them one by one, and then we see whether they are relevant to diabetology, to endocrinology, and to cardiology as well?
So, in a diabetic patient who presents with albuminuria, also with heart failure, the first pillar is going to be the RAS blockade, the form of ACEs or ARBs. As add-on therapy to this, we add SGLTs. We add either dapagliflozin or empagliflozin. The third pillar is going to be beta blocker, and the fourth one is going to be mineralocorticoid receptor antagonist. So these are the basic 4 pillars of managing heart failure in a diabetic CKD patient. So after these, we may also modify ACARB to ARNIs in case of reduced ejection fraction. In patients who have heart failure with reduced ejection fraction, we can add ARNIs in the place of ACE or ARBs.
So these 4 pillars, ma'am, if we could add a 5th one, let us ask your experience as an Indian nephrologist. So all these are built upon an assumption that our nutrition is optimal. So just like Dr. Prakash spoke about thiamine, how frequently do you see macronutrient and micronutrient deficiency in nephrology? And have you ever seen that maybe anemia is causing complications, or maybe protein deficiency is causing complications? And we forget to talk about the 5th pillar being nutritional optimization. How frequent is this, ma'am, in your OPD?
Most patients, most CKD patients are protein energy malnutrition. They also have some water soluble deficiencies. Especially in dialysis patients, we do come across patients who present with vitamin D deficiency. So we supplement them. Similarly, protein energy malnutrition is also seen in CKD patients, especially in dialysis patients and in stage 4 and stage 5 as their appetite drops largely. So we need to advise them on their diet also. So appropriate calories and protein. We give them a chart. We get a dietitian opinion. We also counsel them regarding the diet they should consume. The average potassium intake per day, the phosphate intake per day, everything is given to them so that they have adequate calories and proteins, but not causing hyperkalemia or hyperphosphatemia.
So it's important to look not only at the macro but also the micronutrition. And at least in India, I am not sure about other countries, the 5th pillar must be nutritional optimization. Dr. Murugan, 2 questions. First, the question that came from Dr. Suneet Verma. And secondly, Dr. Suneet, he's a diabetologist. He points out that, again, there is an assumption that everybody with diabetes has got good glucose control. So should glycemic optimization also be a pillar of prevention and treatment for both cardiology and nephrology?
Definitely, sir. Like, there's no doubt that glycemic optimization is the pillar, but that we should not restrict only with the glycemic optimization. That's like there's a reason the recent guidelines is switch from the glycemic approach to the prevention of complication approach. So, though we should target on glycemic approach, the same time we should address prevention of complications. And when we address the prevention of complications, doesn't mean that we should give a leverage over the glycemic control. So glycemic control is a key pillar. The same time, we should choose the appropriate drug or appropriate lifestyle intervention to prevent other parameters to prevent the complications.
And all this put together, now we have 6 pillars, 4 which Madam mentioned: RAS blockade, SGLT2 inhibitor, beta blocker, and mineralocorticoid receptor antagonist. 5th also, which we highlighted, everyone has talked about nutritional optimization. And 6th, glycemic optimization. So what does Thiru Valluvar tell us about all this together? Any suggestions for all of us physicians? How can we become better physicians?
I will say 2 Tirukkurals actually, which I really love. The one is like our MBBS teaching. There is a Noi Nadi, Noi Mudal Nadi, Adudanikum, Vai Nadi, Vai Pache. That means Noi Nadi means first we should diagnose the disease. And second, Noi Mudal Nadi means we should find out the etiology for the disease. Third is the Aldanikum Vai Nadi. That means the proper treatment. All these things compromises the proper treatment. This is what that particular Tirukkural means. The second one, I really I couldn't think how he thought it so many years ahead. That is like, I don't remember exact words. That is one, A called Uttran. Uttran means this is a deceased person. Second, Martuvar, that is a treatment person. Third, I don't remember exact word that he says about those who distribute medications. Fourth, Tunai, that means patient's attender. Fifth is the society. All these things compromises the treatment strategy for the patient. This particular therapy, I couldn't imagine even like how many years ahead he thought even about the attenders of the patient, about that is caregiver of the patient in the treatment of disease. So that means that we should not restrict ourselves to educate only the patient. We should educate the patient's attender also regarding the management and need for proper intervention.
I also read this is known as Thiru Valluvar's quadruple. So Thiru Valluvar's quadruple, and when you read person-centered care, person-centered medicine, if any of us were to read the modern textbooks, we will think it is an American invention. While actually this has been there in Tamil literature and Sanskrit literature for so long. And you are right, person-centered care has come from India. It is not a Western innovation. Dr. Prakash, the 4 pharmaceutical or pharmacological pillars that Dr. Kavya mentioned, she mentioned from a CKD window. But about from the heart failure window, are the pillars the same or is there a slight difference?
It is the same, sir, same. So 2 especially will be same between cardiology and nephrology. So first one will be SGLT2 inhibitor and second one will be RAS blockade or ARNI. So angiotensin receptor nephrilase inhibitor. So an MRAs, if the patient is not having hyperkalemia, and that will also overlap. Beta blockers also. So all these will be having all these 4 pillars. The first 2 will be common between nephrology and cardiology. Yes. So all these will be having a relative reduction of about 25% in reducing the cardiovascular event. The relative risk reduction is around 25% for each one of them.
We want to reduce adverse cardiovascular outcomes. So we have these 4 pillars for heart failure. We also have nutritional and glycemic optimization. If you allow, sir, would you like to add a 7th pillar which talks about cholesterol and platelet optimization? And would you like to speak about this? Is this relevant only for cardiology? Is it equally relevant for Dr. Kavya, Dr. Murugan, and all of us?
Yeah. So as you said, cholesterol lowering agents. So it is for all the, even a person who doesn't have anything, who doesn't have a diabetes or who doesn't have any cardiology or nephrology problem. So they definitely have a primary prevention role. So statins, even at the lowest dose, they will have a primary prevention. So in preventing any macrovascular complication, and apart from that they will be having other pleiotropic effects also. So low dose of statin, it is even for normal people who have a normal lipid levels, and they have to be added as another pillar, as you said, sir. And regarding antiplatelets, you said, so presently there is no evidence suggesting that giving a antiplatelet for a primary prevention will help. So they have a role in secondary prevention, but otherwise many physicians or cardiologists, they add antiplatelet in patients who are at high risk, that is who the ACVD score I mentioned, intermediate risk and high risk, people tend to add antiplatelet along with statin. But antiplatelets till now they don't have evidence. We don't have evidence to support their role in primary prevention. So those who had any event, so in those people it can be added as a secondary prevention agent.
So earlier, that would mean maybe around 15 years ago, we used to prescribe aspirin for primary prevention. And then the guidelines changed. And so many times in my OPD, I would have a booked patient coming back to me after 2, 3, 4 years. Patient was taking aspirin and statin. And now the papers are missing, patient doesn't have. You try to take a history and you're not able to identify whether patient has got established SCVD or not. So after a lot of trial and error, what I realized was if things are not broken, don't try to fix them. So if you have a patient who is taking atenolol and that patient has been taking atenolol happily ever after for past 15-20 years, there is no complication, please do not stop. If patient has been taking nifedipine for past 20 years, it was written in good faith by the physician 20 years ago. If patient is tolerating well, please do not stop. Otherwise, you only will get in trouble. And same for aspirin, if you're not sure, but the patient says, I've been taking for the last 10 years, my physician gave me 10 years ago. Physician is no more, I am still alive. Then you continue. That person would have done something right. Dr. Prakash, so we have got 7 pillars now. And any verse you would like to add from the Thirukural to what Dr. Burman said?
Sir has told about disease, so I'll just go into the values. So my favorite will be Devathan Agadennum Muirchitan Meyurtha Kudidaram. So this Kural itself tells about it. So if a person is ill-fated or he doesn't have the fate to achieve something and he tries, his effort alone will make him to do that, even if he is ill-fated. So that is the meaning of that Thirukural. So I like that very much.
You know, Dr. Prakash, this is useful for me. Thank you. You have made my day, because I struggle a lot with my fate, and now suddenly I'm feeling optimistic. I can work harder. You know what happened to me in personal life? So this astrologer told me that my Saturn is like double Saturn. So it's there in 2 places, and you will have to struggle. So every day I would keep on telling myself, Saturn is making me struggle, Saturn is making me struggle. And then I began struggling. So then suddenly I realized you can change the way you think by changing the way you speak. So then I started by saying, I am being strengthened by Saturn. I am being shaped by Saturn. I am going to achieve success because Saturn is making me strong. I think this is the same thing in the Kural Thiruvalluvar is trying to tell us, that whatever your fate is, you just keep on working hard, you will achieve. So strengthened by Saturn is what I use, and actually now I feel strong. So thank you so much, Dr. Prakash.
Thank you, sir. Thank you, sir. Thank you.
And this is speaking to everybody who is listening to us. That is the beauty, that is the wonderful thing about being in 4D, detailed discussion and dialogue in diabetes, because we learn so much from our colleagues who are sharing their expertise, their experience, their education with us in such an empathic manner. Speaking of empathy, Dr. Kavya, now we have got 7 pillars. 4 are pharmacological, like drug-based, like RAS blockers, SGLT2 inhibitors. We might wish to add GLP-1RA also, beta blocker, MRA. Then 3 are more conceptual. Of course, you need drugs, nutritional optimization, glycemic optimization, lipid and platelet optimization. Let us add an 8th one so that we can complete the octagon of opportunities. That would be psychosocial health. So, ma'am, what does this term mean to you? Dialysis distress. And do you think that distress is dialysable in the endocrine, in the nephro OPD? This comment, ma'am, is coming from a nephrologist, Professor Saurabh Sharma, who works at Safdarjung Hospital in New Delhi.
The mental health is very important. Most of the renal failure patients are depressed, especially when we talk about the term dialysis. It is very distressing, not only to the patient but also to the family. And so we need to address their mental health also. I think the psychological counseling needs to be done to the patient as well as the family. We need to be empathetic, and the entire family suffers when a patient lands up in dialysis. So we need to talk to the patient and counsel the entire family actually regarding the support that has to be offered to the patient as well as the caretakers. That is neglected part. I think we should focus equally on the mental health also.
And what we see is that all of us are speaking the same thing. This is what convergence means. All of us, though some of us deal more with primary prevention, others with secondary, and yet others with tertiary prevention, but we are all dealing with human beings and our thoughts are convergent. We all think the same thing. So to some patient, you may say, Saturn is there, that's why, okay, you got CKD stage 5, but you are strengthened by that. It is making you stronger. To yet another person, you might use religion. For someone else, you might use local wisdom, but you just keep on motivating them to do better and better. Ma'am, Dr. Manisha Sahai, Madam is Professor of Nephrology at Osmania Hospital, Hyderabad. She says that I am discriminating against ladies because I didn't ask you your favorite Kural. So that Dr. Manisha Sahai doesn't get upset with us, what is your favorite Kural, ma'am?
My favorite குறள் is எப்பொருள் யார் யார்வாய் கேட்பினும் அப்பொருள் மெய்ப்பொருள் காண்பது அறிவு. Like it is not a direct interpretation, but still the approach to every patient has to be individualized. We cannot take a common guideline and apply that to everyone. So from a doctor's perspective, we need to be patient-centered. And second, my advice to patients also is that patients randomly hear all sort of treatment from neighbors and try to practice in them. They must understand that what applies to another person may not be suitable to them. For example, an obese patient may benefit from semaglutide, so that may not be applicable for them. So the treatment has to be individualized. So I would to continue.
It has been, for me, I would say it has been a great day, learning so much from our experts, and I'm sure all of us who are watching today share the same sentiments. Our topic for today was, where do the guidelines converge? And we have seen so much of convergence in our thought process, in our words, in the language that we use, and in our action also, whether it is in the OPD, whether it is in the ICU, or maybe in the dialysis ward. Dr. Murugan, thank you so much. Dr. Prakash, thank you. Dr. Kavya, thank you. You have made our day. Before we conclude, perhaps just one sentence, and let's start with Dr. Kavya. Otherwise, Dr. Manisha Sai will get angry at me. Madam will get angry. So, Dr. Kavya first, one sentence, and your audience is all physicians of India watching us today. One take home.
So we need to start from prevention. We cannot like change the treatment after the patient has landed up in ESRD. So everything starts with prevention. So we need to prevent macrovascular and microvascular complications in a diabetic patient. So we need to start with prevention.
Thank you. So promotive health, proactive health, and prevention. Dr. Prakash.
Yes, I will also tell about prevention only. Walk 30 to 45 minutes per day. That will clear most of your problems, whatever it is cardiology or nephrology related or it is diabetes related. So walk for 30 to 45 minutes per day.
So practice what you preach. And Lord Murugan will always have the last word. So Dr. Murugan, last word from you.
And I would like to use the word intervention rather than treatment in diabetes. So the moment we plan a treatment, we should call the intervention in terms of exercise or physical activity, intervention in terms of diet, intervention in terms of drug, intervention in the terms of regular follow, and intervention in the terms of, as you said, psychosocial aspect of the patients. So whenever we choose a treatment, we should intervene in all these aspects and let the treatment be the complementary for the patient rather than just give a prescription to the patient.
So intervention, assistance, and you just add the treatment, the pharmacological treatment as an adjuvant, and then that improves acceptance and adherence. Thank you so much to all of you. Thank you everyone for being with us, and stay tuned for our next episode of season 3.0 4D. Thank you everyone. Jai Hind.
Thank you.
Thank
Thank you, Mrs.
Thank you, sir. Thank you.